Bye.
Hello, welcome to Knock Knock Eye with me, your host, Dr. Glockenflecken, your one-stop shop for all things eyeball related. I do have some eyeball stuff for you today. But first, all right, look, I'm just going to get this out of the way because I am tired of hearing about the Epstein files and reading about the Epstein. It's disgusting. It makes me feel bad. And everything is just awful about it. And I want everybody involved to be brought to justice and everything like that everybody else says too. It's just vile, awful things. I don't even need to preface this with that. We all know that. But in the world of medicine and physicians, and it's kind of there's been a lot of chatter, a lot of talk about Peter Attia, one of the most popular, maybe popular is not the right word. He is very popular, but maybe one of the most public, most well-known of doctors out there in the world, with massive amounts of followers and subscribers and everything. And he's in the file, like sharing 1,000 emails with Jeffrey Epstein. Obviously, this is gross. This is terrible. And I do not subscribe to Peter Attia. I've honestly rarely ever see any of his content unless it just comes across my feed. And I'm not a longevity guy. I think there's a lot of pseudoscience going on there. Questionable conclusions and claims. And so I'm not into that. But the Peter Attia and Epstein thing, I've seen a lot of think pieces. I've seen a lot of people are in their feels a bit, especially just the average person, not so much in the medical field, but just your average listener of Peter Attia, they're kind of feeling themselves and trying to wrap their heads around this person they've built up in their mind as a someone to respect and to listen to and to trust, and trying to reconcile now what they think about how vile it is that someone would be cavorting and interacting and friendly with Epstein. And this is all I'm going to say. Just one thing. If there's one thing that you take away from what has happened to Peter Attia, it's that if one thing you can do in your life is if someone all right, or someone you're thinking of interacting with or forming a relationship with, if it turns out that person is a convicted sex offender, don't do that. That's it. Just don't do it. Don't do it. It's so easy, isn't it? Like Attia, it could have been like as soon as he found out that Jeffrey Epstein was a monster, at that immediate moment, no communication, back away, get out of there, and everything would have been fine on that front, at least. It's so simple. This person I'm about to send an email to, a 5-second Google search turns out convicted sex offender. I'm not going to do this. This is not someone I want to be friends with. But he didn't do that, and he had this friendly relationship, and so just don't do that. Very simple, very, very simple. All right, that's all I'm going to say about it. I don't even want. Let's talk about more interesting things, and things that is more fun to talk about in the world of ophthalmology. I got two big topics that I find kind of fascinating. One is we got to talk about. Okay, I'm going to preface this by saying, this I'm kind of talking directly to my ophthalmology colleagues for a lot of this, but I think a lot of people in medicine are going to relate to this as well, particularly primary care cardiologists. As the field of ophthalmology, we need to come together and figure out this whole pre-op H&P thing. So for those of you who are not in medicine, I'm just going to lay it out for you, like what the issue is here. So ophthalmologists, one of the most common surgery that's performed in the US is cataract surgery, because everybody, we've talked about this so many times, everybody gets cataracts. Everybody over 60 has cataracts. Eventually, if you live long enough, you're going to get cataract surgery. That's just the way it is. It's a 7-minute surgery, and it's amazing. Gives your vision back. It's awesome. All right, 7-minute surgery. Like maybe the average is like my surgery is like 7 minutes. Average is probably like 8 or 9 minutes. The point is it's a very quick surgery. And so these are done in typically outpatient surgery centers, unless the patient is too sick and they have to go to a hospital. But upwards of, I would say 90, 95, maybe 98% of cataract surgeries are going to be done in an ambulatory surgery center. So basically not like an inpatient hospital setting. All right. These are like day surgery. Like you come in, it's a place that's designed to come in, have your surgery, you go home all in like a couple hours. A lot of these places are owned by ophthalmologists. A lot of them are not. A lot of them have different specialties that come in and out. Some of them are just ophthalmology. And then for the sick patients, you go over to the nearest hospital. So just in case something goes wrong with the patient, you have a higher level of care ready and waiting at this hospital. The vast majority of cataract surgeries, I would say, are staffed by CRNAs, all right, nurse anesthetists. Sometimes it's an MD, an anesthesiologist that staffs the surgery, that gives the anesthesia. But in general, you don't have to have that the highest level of care for a cataract surgery, because again, it's a 7-minute surgery under minimal sedation. Patients are awake during cataract surgery. All right. And so I remember at the VA, whenever I was doing training in residency, we had an RN, not even a nurse anesthetist. We had just a regular RN staffing the surgery. We would give the patient in pre-op 5 milligrams of 5 milligrams of diazepam, oral sedation to these veterans, which for a lot of them, they had a history of heavy drinking. And so it was like giving them water, basically. So it didn't do a whole lot sometimes, but it was enough for most of the patients that they were able to get through the surgery just fine, because again, 7-minute surgery. So here's what the problem is, that a lot of surgery centers over the years have instituted policies, like policies to quote unquote safety policies, ways to increase the safety of surgery for patients that come to that center. And I was alarmed to find a social media post where it was a physician who is going in for their own cataract surgery, and said that that the practice had a policy where every single patient that comes through that surgery center associated with that practice had to have a pre-op history and physical with a primary care doctor within like 30, 60 days, something like that, of the surgery. Every single patient. Remember, everybody gets cataract surgery. 7-minute surgery, minimal sedation. You're not put to sleep. You're awake, but you're calm. You get a little bit of relaxing juice. You get an IV, maybe you get a little Versed. That's typically what it is. You get like a milligram of Versed, maybe a little fentanyl, and make you feel relaxed and decrease any kind of pain you might feel, and then you're done. And I was kind of, I knew that the pre-op H&Ps were a problem. I didn't realize it was like that level of a problem, where you have practices out there that are requiring every single patient who comes into a surgery center to show up having had a pre-op history and physical with a primary care provider. It seems a bit overkill, doesn't it? So there's a lot to unpack with this, but first of all, this has been a complaint with my primary care colleagues for years. It's like a running joke. In fact, whenever I go and speak to primary care doctors or cardiologists, I always open with a joke. It's like, first off, I just want to say, on behalf of the entire field of ophthalmology, I am so sorry for sending all of our patients to you for medical clearance prior to surgery. It always gets a big chuckle because everybody understands, like, oh yeah, that sucks. Why do you guys do that? It's kind of embarrassing. And people want to like blame the doctors for this. Trust me, I would love to be able to just clear, quote unquote, clear, because there's no, you don't clear a patient for surgery, you guys. It's a preoperative risk assessment. You're determining preoperatively what is the risk that this patient within a 7-minute surgery under minimal sedation might have a heart attack or stroke and die, or have a heart attack or stroke, or death, or anything in between. What's the risk? All right. And I might be an ophthalmologist, but I can talk to a patient, get a sense of their history, even just look at the patient and determine, oh, this is someone who does really need an assessment by someone who has more expertise in heart and lung medicine than I do. I can determine that. I'm good at that. I can do that. A patient comes in who has a history of well-controlled atrial fibrillation. They see their cardiologist every year. All right. No recent hospitalizations, no history of heart attack, stroke. I can do a heart and lung exam. I can clear that. I can say this patient is safe for surgery. And that's the way it works at my surgery center too. Like I can get the ball rolling on whether or not a patient needs a pre-op assessment by somebody other than me, someone that they see, their cardiologist, primary care, whoever it is. And so I try to do that as judiciously as possible. And so this problem where ophthalmologists send patients who are about to get this minor surgery to a physician and take up a spot in that person's schedule just to say, oh yeah, this patient's okay for surgery, which often is not even a billable event. Like often it takes up time and they may not get paid for doing that, or for signing that piece of paper, or for going through the chart, or however the primary care doctors do this. So that's where the conflict comes in. That's what they don't like about it, because it takes time. It's not reimbursed. We're making them do unpaid work often for something that, as a physician, as someone who went to medical school, I should be able to look at this stable person who has this medical issue, whether it's atrial fibrillation, peripheral vascular disease, COPD, well-controlled asthma, whatever it is. I should be able to look at them and determine this patient's okay. They will survive. They will do just fine during this minor surgery. Or I can look at this patient and determine, I'm not sure this seems like a high risk, even this small surgery, a little bit of sedation, the stress of a surgery, even though it's only 7 minutes, seems like it might be a little bit too much for this patient. I'm going to let your doctor know that I want to do this and make sure that it's okay. Or make sure you don't need some kind of optimization of your systemic medical issues prior to having this minor surgery. Any ophthalmologist, anybody who went to med school needs to be able to do that without question. So you have the cardiologists and the primary care doctors, family medicine doctors, whoever it is, they get upset with us, ophthalmology, because they get all these patients that need clearance. And the thought is like, why are these doctors doing this? But let me tell you exactly what's going on, because I would guess that most ophthalmologists would be fine with doing it the way I do it. All right. Making that determination. But the corner that we've trapped ourselves into is the regulation of surgery centers. All right, which are often, set in place sometimes by physicians, hopefully with the guidance of physicians, but also by anesthesia providers, by administrators who are not physicians. And all they're thinking about is risk. They don't want their surgery center, and by extension, their doctors who work in their surgery center, to be on the hook, liability wise, in case something goes wrong with that patient that they did not expect, whether it's a heart attack, stroke, whatever. And so they're thinking about it from a liability lens. And so what happens is, in order to try to deflect that liability onto somebody else outside the surgery center, they put a policy in place that says, okay, well, we're not going to we're not going to clear the patient for surgery. We're not going to, we're going to let the patient's other doctor do that. That's not affiliated with the surgery center. So if something goes wrong, we can point to this piece of paper that somebody else signed that said, oh no, this patient was safe enough for surgery. It's kind of gross. Like it's kind of, it's the liability blame game. It's what is so prevalent in this country in the medical field in so many different ways, whether it's imaging results, whether it's curbsiding specialists to say, so you can say in your note, well, I ran into the neurologist and they said it was okay not to do this, so we didn't do this. It's deflecting liability because everyone's so afraid of getting sued in this country. And so now we're in a situation where you have surgery centers, outpatient surgery centers, that are requiring every single patient that gets cataract surgery to have a visit with a doctor that's already overworked and underpaid and stressed. We're just adding to that burden because we want the blame to be on them. If, God forbid, one of the rarest of rare events during a 7-minute surgery, something goes wrong systemically. I don't know. I feel so bad. It's embarrassing. I kind of feel embarrassed for my field, but I know that for the most part, it's not really, in some situations, it's not on us. Now, there are ophthalmologists that are like, I will not touch a stethoscope. Somebody else is doing this pre-op H&P, and that's not okay. Like you know what a lub dub sounds like. Like, you know what a breath sound sounds like. So, you don't lose that just because you've been seeing eyeballs for 20 years. Like, suck it up. Pick up a stethoscope, listen to a heart. Look at the patient, look at their history. Like, this is like first year med school stuff. This is not that hard. I have a big problem with surgeons who knowingly, willingly send all of their cataract surgery patients to somebody else to sign off on the health of the patient. Some patients need that. Yes, some patients do need that. Some patients are very sick. They're on oxygen all the time, or their lungs sound like crap, or they had a heart attack a month ago, or they just had some kind of valve replacement surgery not too long. Like, those patients, yeah, if I was their doctor, I'd be like, I'd want to know that my patient, you're going to do a procedure on my patient. So I'm not talking about that. I'm talking about just the average, healthy 55-year-old who gets referred to a primary care doctor just to sign a piece of paper accepting liability in case in that 7 minutes a stroke happens. That sucks. That's not the way we need to be collaborating with our colleagues. And I know it's a soapbox. But I don't know what to do about it, because it's more of I think a symptom of our healthcare system and how litigious it is. But if you're an ophthalmologist listening to this, like, change the way you do it. If you are resonating with what I'm saying, if you feel like I'm talking about you, like, do something about it. Because we don't need to be doing this to our colleagues in medicine. Like, do something different. Talk to your CRNAs, talk to your administrators, like, come up with a different plan. and let's fix this. All right, let's take a break. Hey, Kristen, did you notice what I was wearing last night?
Yes, you wore a set of pajamas and they matched.
Not just any pajamas. These were Cozy Earth's bamboo pajama set.
Those are the best ones that I have ever had. They are legitimately like my favorite ever.
They're lightweight, but they're also
Yes.
warm, and I felt very comfortable. I had wonderful sleep. And now you can get a 100-night sleep trial. Try them out. If you don't like them, send them back.
Yeah.
You also have a 10-year warranty with these things.
Nothing to lose.
Share a little extra love this February and wrap yourself or someone you care about in comfort that truly feels special. Head to CozyEarth.com and use my code KNOCK for up to 20% off. And if you get a post-purchase survey, be sure to mention you heard about Cozy Earth right here. Celebrate everyday love with comfort that makes the little moments count.
Hey, Will.
Yeah.
You know, it's February. It's the month of love.
It sure is.
Do you know what I love?
Me?
Well, yes. But do you know what else?
I don't know what.
I love eyelid mites now.
You?
Yep.
Eyeballs too, right? Not just the mites?
No, just the eyelid mites. Yeah.
Oh, okay, well, that's a start.
But I was just thinking that since they're so common, like 1 in 12 adults has an overgrowth of eyelid mites, so I should be more accepting.
That makes sense. It's very normal for Demodex mites to be in and around your eyelids, too.
Yes. And I know that if they do happen to overpopulate and cause Demodex blepharitis, there's a prescription eye drop treatment, so no need to stress.
So relax. See, if you ever have itchy, irritated eyelids, just go see your eye doctor. They can examine your eyelids, check for crusties, what we call collarettes. Those are the things that mites leave behind. To learn more about eyelid mites and Demodex blepharitis, visit miteslovelids.com. Again, that's miteslovelids.com to learn more. This ad is brought to you by Tarsus Pharmaceuticals. Okay, so your medical topic for today, it's kind of a different one, and it has to do with LASIK. So all you people that are always asking me about LASIK or interested in LASIK, listen up. We recently on Knock Knock Hi, this episode will be coming out before the episode I'm referring to, but we just had an interview with Dr. Claire Brandon, who's a GI psychiatrist, which I learned was a thing. Is fascinating stuff. That we are finally understanding that the brain, which includes the mind, which includes psychiatry, it's a part of the body. It embryologically, it all comes from the same groups of cells, right? So it makes sense that physical pain, whether it's GI, your heart, your lungs, your eye, whatever it is, it's inextricably linked to what's happening in your brain. Whatever inflammatory cells that are going to your gut, if we're talking about autoimmune disease, and it's causing disease in your gut, those same cells, they circulate through your brain too. They're going all over your body. So it's this idea, and this is what Dr. Brandon talked to us about, this idea that it's either or. Like, oh, I can't find anything wrong. I can't find anything physical in your abdomen to explain your abdominal pain. So then it must not be that. It's something in your head. It's anxiety, whatever. That's not the way to think about these things. You can't extract the two. The pain is real that someone's having, and maybe it is a psychiatric condition that's exacerbating that pain. And so dealing, and you have to address both. You have to address, so that's why, Dr. Brandon, GI psychiatrists like her, collaborate with other doctors so that you're working on these types of problems that are very difficult. Pain is such a difficult thing to treat for chronic pain. But you're attacking it from multiple sides. And you're not just like, well, I don't see anything wrong with you. I'm signing off. Go see a psychiatrist. Not the way to address these things. But I've been thinking about this idea ever since we finished, talking with Dr. Brandon, and I'm thinking about it from the perspective of an ophthalmologist, obviously. And there's one thing that keeps like kind of rooting around in my brain, and that's the incidence of pain after LASIK. So there are a lot of patients. I mean, not a lot. There's enough to have like support groups because this is a huge problem. But there's a small percentage of patients who have had LASIK that end up with severe, what we think is neuropathic pain. And these are such challenging cases. It's extremely rare. I don't want to scare people off of LASIK because LASIK can be life-changing for people. But a very, very small percentage of patients do have this neuropathic pain after LASIK. And there have been cases of people like driven to suicide over this pain. And incredibly sad, awful, and fortunately, extraordinarily rare, like that happens. Um, Obviously, there's potential side effects, sometimes devastating side effects for so many things we do, and that's why informed consent, making sure people understand the risks of what they're getting into, is really important. This is extraordinarily rare. I want to make that clear because LASIK, it can be life changing for people. It can, and I actually personally don't do LASIK, but I have referred patients to my partners for LASIK who I think would really benefit from it, decreasing the necessity of using contacts. And contacts alone can increase your risk of infection and severe dry eye down the road anyway. So there's pros and cons, and it's a personal thing whether or not you want to have laser refractive surgery. But it makes me wonder, like, okay, these patients that they come back, and I've seen a few of them that have constant burning discomfort, can't keep their eyes open very long, and drops. You try everything you can. You try serum tears. They got severe dry eye type symptoms, but you look at their exam and it looks normal. It's so challenging for not only the patients. Obviously, it's exasperating for the patient to have to deal with this, but also for the doctor, because what we absolutely, especially if someone that we've done surgery on, we do that, wanting them to get better, and they come back, they have this horrible pain, they're unhappy. It's one of the worst feelings as a physician, because we got into this to make people better. And when you make someone worse, incidentally, it feels awful. It feels awful. And so, what do you do? What do you do for those types of patients? Well, first of all, you do keep seeing them. You never, and I've never once done this, someone who I've harmed, with surgery, because it happens to every surgeon, like, you don't forget about those patients. You don't say, there's nothing more I can do for you. Well, at the very least, you can always keep seeing the patient. You can keep having conversations. You can support that patient by seeing them periodically, right? You don't just throw your hands and say, sorry, I did the best I could. That's how you alienate people from the medical system. That's how you get people that show up on social media and just talk about how awful doctors are, because they've had that kind of experience. So you don't forget about those patients. But now, after talking about this whole gut brain thing, now I'm thinking, like, maybe I should be more proactive for the rare times that patients like this come in where they have pain, corneal pain, pain around their eye, on their face. There's been a handful of times over the years where patients have come in to see me, and me, ENT, primary care, neurology, nobody can figure out why they're having this pain. And really, not once have I thought, like, let's see if psychiatry can help. First of all, that is it's a challenging thing to bring up because there's a lot of bias. And so I think framing it, and I talked about this with Dr. Brandon on the podcast, but framing it in a way like to make it clear, this is just another tool in our toolbox. Like, I'm still going to see you. I'm going to still work with you, trying to find a eye drop regimen or medications that can help decrease that pain in your eye. But this is another person who might be able to help, who has expertise and the how the body and the brain, because the brain is the body, how it all relates, and how psychiatric treatments, whether it's therapy, medications, whatever, uh, can maybe help dull that pain stimulus. I just never haven't thought about it that way. And we probably need to be thinking about that as a collaborative thing, not like well, I can't figure this out. There's nothing else I can do. Let's send you over to the psychiatrist. You're their problem now. And now I'm going to be thinking about that, for these patients that come in. And I think it's just, why not use every tool in your toolbox, and I think a lot of these patients are very desperate, and they'd be open to that idea as long as you just frame it correctly, right? And don't make them seem like you're giving up, and that you think, as the physician that who did their surgery or whatever, or who's been seeing this patient, that I think it's all in their head. Like, you can't that's not appropriate. But there's a way to frame that. It's not unusual to, like, the eye, the brain, sensation. I think neurology, ophthalmology is a place where you can get a lot of vague, like, pain complaints, like headaches that you can't really figure out exactly where that's coming from. And what do you do? How do you treat that? How do you make this person better? They're coming to you for help. They're paying you to help them. And so there's such a strong desire to fix it, to have an answer, but sometimes you just don't have an answer. And that's jarring for physicians. I think patients are probably more used to that, honestly, than doctors are. We're so used to having the answer for everything. And so when we don't have an answer, it feels wrong. Some patients are probably like, man, well, nobody else knew it. And I hear that sometimes. Nobody else knows what's going on either. And so psychiatry's there. It's an option. LASIK's great though. I really don't want, the takeaway here is not like I'm never thinking about or doing LASIK. LASIK's been around for 30 years now plus, and it can be super helpful for the right patient. And I've said this before, when I've talked about refractive surgery, it's okay to get second opinions, especially when it comes to, like, a procedure that's not an emergency. Like, yeah, go if you can afford it. If it's not like an issue with insurance, which what isn't an issue with insurance these days, get a second opinion. All right, because I hear lots of shady sounding ads on the radio. Yes, I still listen to radio in the car. I love it. Uh, they're hawking, like, laser, or laser refractive surgery, or refractive lens exchange. All these procedures. Get a second opinion. If someone says, "Well, I think we should do this," it's going to cost you $5,000 an eye. Talk to someone else first. Totally fine. I love it. I actually love it when patients either come to me for a second opinion, or request to be sent somewhere else for a second opinion. I'm fine with that, because that person, the patient, needs to feel comfortable with who's doing their surgery. If that means going to talk to someone else first, and who knows, they may stay with that person, that second opinion. And a lot of times they come back. Like, okay, well, I get, let's go ahead with surgery. I'm convinced. All right, great. All right. I want my patients comfortable. That's it for Knock Knock Eye. All right. I appreciate it. Kind of a serious episode. Sorry about that. But a lot of stuff going on in the world. But, in summary, don't be friends with pedophiles. Be judicious with your pre-op referrals for history and physical. And think of psychiatry as a part of the healthcare team, and as someone you can work with collaboratively. So that's it. Thanks for joining me. I'm Dr. Flecken, also known as Will Flannery. Thanks to my executive producers, Aaron Cordy, Rob Goldman, and Shanti Brick. Editor and engineers, Jason Portiza. Our music is by Omer Benzvi. Knock Knock Eye is a human content production. See you next week, everyone.
Knock, knock. Goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Hope you subscribe, leave a comment below. Let us know what you think.